Hey y'all, my name's Taylor and I'm an occupational therapy student. And for this week's Journal Club Forum, I was assigned cognitive behavioral interventions. And so I wanted to give y'all a quick definition of what cognitive behavioral therapy is. It's also known as CBT, and it's a form of psychological treatment that has been demonstrated to be effective for a range of problems, including depression, anxiety disorders, alcohol and drug problems, marital problems, eating disorders, and severe mental illness. And numerous research studies have suggested that CBT leads to significant improvement in functioning and quality of life. And in many studies, CBT has been demonstrated to be effective as, or more effective than other forms of psychological therapy or psychiatric medications. And so for some basic information, the title of the article I chose is Family-Centered Cognitive Behavioral Therapy for Anxiety in Very Young Children with Autism Spectrum Disorder. There were 5 authors for this study, and the journal it was published in is the Journal of Autism and Developmental Disorders, and it was published March 7th of 2020. So to give you a brief overview, the goal of the study was to address the paucity of cognitive behavioral therapy protocols available to treat anxiety in preschoolers with ASD. And this study piloted a family-centered CBT protocol in a series of 16 children aged 3 to 7 years with ASD and anxiety disorders, and it explores its feasibility and just how efficient it was in doing this. And the whole reason why they wanted to do this was because the National Autistic Society found that anxiety was the second most frequently cited problem reported by parents, and approximately 40% of those children develop anxiety disorders. And the most prevalent disorders are generalized anxiety disorder, separation anxiety disorder, social phobia, and specific phobias. And anxiety in children with ASD can exacerbate social impairment, affecting daily living skills and relationships with peers, teachers, and family members. And this is really important because the psychological or psychosocial treatment of choice in typically developing children is CBT, as other studies have proven that CBT is effective in reducing anxiety disorders and symptoms. And so these researchers really wanted to see if this would have the same effect on children with autism. And so the research design, it's a mixed method design, and this really promoted triangulation, meaning it used 2 or more separate research methods to collect data. And these techniques were used to help confirm study results. And this is an open pilot study with no control group, meaning they have no control group, but also that all sides of the party were aware of the goals of this study. So parents and the children were aware that this study was to see if CBT is effective for children with autism. And the children were assessed at baseline, post-treatment, which they refer to as PT, and a 4-month follow-up, which is referred to as FU throughout the article. And it uses diagnostic interviews, parent questionnaires, and mini assessments. And the level of evidence is a level 3, as it uses non-randomized studies without a control group. As far as the methodology, the participants, there are 16 children with ASD in this study. And as far as the location goes, that was a outpatient clinic of 2 urban hospitals affiliated with a medical school. For inclusion criteria, they had to have a ASD diagnosis, a DSM-4 anxiety diagnosis, the age range of 3 to 7 years, and a documented IQ score of 80 or above. And this was verbal or nonverbal. For exclusion criteria, they had to have previously had CBT for anxiety, presence of conduct or oppositional defiant disorders, ADHD so severe that it would interfere with the child's ability to take part in treatment, presence of a primary presenting problem for which the intervention would be inappropriate, and this would be obsessive compulsive disorder or severe mood disorders. And then also the presence of suicide or suicidal thoughts, and this could be in a child or the parent. The children were recruited from a developmental clinic at a children's hospital, which they got 15 participants from that hospital, or from a university-based program that was assessing children with ASD, and they got 1 participant from that. As far as procedures went, the first step was a brief telephone screening where the researchers were on the phone with the parents. And after the telephone screening, the children and families attended an initial screening visit, and this was to just determine their eligibility to participate within the study. The third step was a baseline assessment visit, which the researchers refer to as BL in the article. And this was done in part of like the parents would come and complete an interview, questionnaires, and these interviews and questionnaires really focused on the child's symptoms and the effects that it's having on the family. And then these interview questions that were asked were really based on the DSM-4 criteria. Also at baseline, there were some measures that were done. So the KIDDie schedule for affective disorders and schizophrenia was completed, as well as a list of the child's most feared situations that was generated. And the child also underwent a language screening. And to do this, the researchers used the clinical evaluation of language fundamentals. And then the fourth step was treatment, and this is where the children were treated in individual parent-child treatment sessions, and all the assessments that are listed were used at baseline, except for language screening for post-treatment and 4-month. And then at post-treatment follow-up, which was the fifth step, and the 4-month follow-up, which is the sixth step, only the anxiety modules were administered. And then for the clinician measures, these were measures and assessments that were completed by the researchers. And to assess the anxiety and other psychiatric disorders, clinicians administered the KIDDie schedule for affective disorders and schizophrenia. And then to evaluate the feasibility of the treatment for children with varying language levels, they evaluated this at baseline using the clinical evaluation of language fundamentals. And then to rate the current symptoms of anxiety at baseline, post-treatment, and follow-up, the pediatric anxiety rating scale was used. And this is a 50-symptom checklist based upon interviews with the parent that assesses the severity of anxiety symptoms. And then to assess the changes in the child's ability to manage specific anxiety-provoking situations, the coping questionnaire was used. And then the last one used by the clinicians was a clinician-rated kind of assessment. It was called the Clinician Global Impression of Anxiety. And this is just like it uses a 7-point scale. So the assessments and measures used by the parents were the child behavior checklist parent form, and this was completed at baseline, post-treatment, and the 4-month follow-up. And this was a standardized parent report assessment of the child's behavior problems and social competence. And then the parents completed the social communication questionnaire as a supplemental questionnaire of social communication ability at baseline. And then to assess the extent to which the child participates in activities typical of the families with young children, the family life impairment scale was used. And then to obtain weekly parent ratings of anxiety problems using a brief measure more sensitive to change. And anxiety, unlike the child behavior checklist parent form, the parents just rated their child's symptoms at baseline, weekly throughout the treatment, post-treatment, and follow-up. And then the measure used on the child themselves was the Koala Fear Questionnaire. And this was a pilot to pilot the feasibility of obtaining the child report data about feared questions. It was used, and this just presents 31 potentially fear-provoking stimuli. The stimuli was illustrated in pictures, and the child would rate each stimuli using a 3-point visual scale. So it was pictures, and they would point to it. And then for treatment, they used what was called the Being Brave protocol. And this protocol includes direct treatment with the child and parent. And then there were 14 sessions. And so session 1 through 3, these were parent meetings that provide psychoeducation on the CBT model for treating anxiety and how parents respond to their child. They focused on cognitive restructuring and modeling coping skills. In sessions 4 through 6, the researchers taught parents to play with the child in relaxing ways, how to use specific praise, how to reinforce coping responses, and how to plan and implement gradual exposure to CBT. And then in sessions 7 through 13, they taught the child and the parent skills for managing the child's anxiety by teaching coping skills. And these coping skills could be relaxation exercises or coping plans. And then for the very last session, this was another parent meeting. And for this session, they wanted to address maintaining these gains and how to continue this work outside of these sessions. As for the results, at post-treatment, 81% related very much or much improved on the CGI anxiety assessment, which was great. That was a great outcome. And then the children displayed significant decreases in clinician and parent-related anxiety and improved family function and coping. So they found just a decrease in anxiety overall. And then these gains were also maintained at the follow-up. So the 4-month follow-up after the sessions and the intervention treatment was done, they found that they were still having gains. And then the parent-child CBT is feasible for young children with ASD and anxiety, and this shows potential for similar efficiency as neurotypical children. And so pretty much this just says that CBT is just as feasible and works just as well for children with ASD as it does for neurotypical children. And then for article appraisal for strengths, I said clinician expertise. They had great knowledge on just children with autism. They had worked with children with autism before, and they've also practiced CBT before. They had extensive knowledge about the assessments that were being administered. They had administered these in their practices previous to the research. And then they also went through a formal training session prior to starting this research. The second strength was the assessment and measures used. The assessments themselves found to be very valid. They had inter-rater reliability, retest reliability. They had internal consistency. They had test-retest reliability. So they really made sure that they picked good assessments. And then the third strength is CBT treatment was delivered the same way as it would be in typically developing children, and there was triangulation. As far as weaknesses go, it was an open pilot study with no control group. It relied on parent and clinician outcome measures. And then it was limited by the availability of measures validated for children with ASD in this study age range. And so that's just because the children were so young. And the participant demographic, the participants were largely European American, middle class, and living with 2-parent families. It's not really sure how, they weren't really sure how the results would be generalized to families living in more stressful economic and social circumstances. And as far as relevance, anxiety in children with ASD can really exacerbate social impairment, affecting daily living skills and relationship with peers, parents, and family members. I stated that in the beginning of the PowerPoint. And failure to treat anxiety in children with ASD can lead to unhelpful management of symptoms. And CBT is commonly used intervention method to combat anxiety. And again, like I stated, 40% of children with ASD develop anxiety disorders. And so this is pretty prevalent in this population. And because we as OTs, speech pathologists, PTs, we're going to work with these children who have these disabilities and anxiety. And so it's important that we know how to treat them. And using CBT is one of those ways. And these are my references.